right, so we'll start off with a quick walkthrough through the program, to the course. And we have the welcome, of course, here. Here's my information. And feel free to text me at that number if you have a question or anything. Um, the preference is to use my email, so it depends on what the question is, whether or not I'll answer you, or I might tell you to email it to me. Um, I usually do a pretty good job of getting back within 24 hours during the week. The weekends from Friday through Sunday, I won't get back to you until Monday, most likely. So sometimes I check it on the weekends, sometimes I don't. Uh, your textbook, of course, is Abnormal Psychology and Life by Kearney and Troll. Uh, Overall, it's a pretty good textbook. Our syllabus. Okay. And again, there's my information, my phone number. If you need to meet with me for office hours, or if you have just want to meet and have some certain questions on either one of the chapters or one of the assignments that's going to be due, by all means, just I'm happy to meet up with you. And this is the origins, development, and treatment of abnormal and maladaptive or deviant behavior in society, the etiology, where it comes from and how it starts, and the diagnosis of abnormal behavior. And it's an overview of treatment methods. So as we go through each diagnosis, there'll be some forms of treatment that work better with with other diagnoses than others. And you will also need the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, to go along with this as well. The second week is an activity for the DSM-5, so you'll definitely need one in order to answer all the questions and get those points. So those are the texts, Kearney and Troll, and the American Psychiatric Association DSM-5. This is an online course, and so I was looking forward to in person, and then we ended up being online. So that's okay. We'll get it knocked out. And we lost online, or lost in person, but we gained Logan. So that's nice that we were able to get more students than what we were supposed to have. So if anybody's from the Logan campus, welcome. And glad that you could be here with us here in London. So ultimately, the goal is to demonstrate an understanding, a global understanding. So not specifics, but just enough to know the whole thing. Even as a practicing clinician, I don't know the DSM-5 backwards and forwards. It's a reference, and it's used as a reference. So this course is to help you get familiarized with using the DSM-5, how to read the criterion for diagnosis and things like that, which you won't do until you get master's level anyway. And so this is really just to get you kind of familiarized with it. And then exhibit an understanding of the classification of abnormal behavior, the ICD codes, and things like that. And then ultimately recognize and distinguish the symptoms of mental illness in the major DSM-5 categories. What's the difference between anxiety and depression? What's the difference between bipolar disorder 1 and bipolar disorder 2? And so PTSD, all those things, what are the differences in that? And you can read through the human services learning objectives. We'll jump down to our assignments. So how you interact with each other, and especially in like any discussion forums that we might have, how you interact with me is important. It's important to start working on professional development even right now. We want to make sure that as you move forward in your education, whether you stop at a 4-year degree or keep going on to you get your master's or even your doctorate, that working within the human services uh, area, we want to make sure that you're working on professional development and how you interact with not only your colleagues but also the public. So, professional and behavior and class participation uh, is not worth any points, but points may be deducted if there's poor professional behavior and class participation. So, you want to make sure that you're maintaining those things. I've never ever had to deduct points, so I don't think that's usually an issue. Um, your first thing to do is this week is your introduction. And besides reading chapter 1 and 15 and doing and reading through the PowerPoints for those as well, the only thing that's really due this week is your introduction and responding to at least 2 peers. That's all due by Sunday at midnight. Our program week goes from Monday until Sunday, so almost everything that you'll have due is going to be due Monday at midnight, Monday at 11:59 technically. You are going to have 6 quizzes, and those will start next week. And I will post those. I think I said on Monday or Tuesday. I think Monday of the week. So the first day of the week before midnight, I will post it. So if it's not posted by 4 p.m. on Monday, it's okay. It will be posted Monday sometime. Okay. Um, you will have an APA paper due, and that is a minimum of 4 content pages. That does not include the cover page, nor does it include the references. So 4 pages of content, and when it comes to that, and I'll do probably a video just on the APA paper, but when it comes to an APA paper, 4 pages of content minimum means not 3 pages and 2 lines on the next page. It means actual 4 pages of content all the way to the bottom of the 4th page. Um, Believe me, when you're writing about any of the diagnoses, it's really easy to fill 4 pages. It may not seem like it, but this is actually a really good time to start working on your writing skills, because if you do want to go on to the master's program, it's a lot of writing. And so you might as well work on it now and start developing good APA formatting. APA is the format that you're going to use, whether you go into counseling or psychology for your um, professional degree, your master's degree, or doctorate even. And so um, I really like to give just feedback. I mean, as long as the content's good, you're going to get a good grade on it. All the other stuff we can work on. I mean, that's what we want to work on, is help you develop your writing skills if you're going to move forward, especially. And so you might get a paper that's all tore up as far as the markings go, but things like APA format, I don't take a whole lot of points off of, because you're just learning it. Same thing with grammar and other writing. You know, a lot of times one of the biggest issues that we have is that um, professionally we cannot write like we talk. So professional writing, such as a paper or something like that, has to be done professionally, and so we can't use anecdotes uh, of a like a real personal nature. Depends on what we're writing about, but you want to make sure that you're not using uh, colloquialisms, which are common sayings that are used locally, things like that. And by the way, if anybody has a question, just pop up and ask a question as we go along. You don't have to wait to the end. And then using the DSM-5, that's an activity that I believe is going to be due next week as well. And so you'll have the quiz in this, and it's got 40 some things that you have to look up and find page numbers or write a description about. Um, and it's pretty simple. I think it's already available to you. It does take some time to get through it. So if you have your DSM-5, make sure that you print that paper out so that you can write it out or scan it, however you want to do it, and submit it next week. And then, of course, the last thing that we have is a final exam, and I have no idea why it goes from 5 to 8, but I missed that. So there's no 6, 7 in there. It's just 5 to 8. Um, the final exam will be during the last week. I usually open it up on Tuesday or Wednesday and and you'll have it until Friday. The way that the grading in the semester goes, um, usually all the coursework is due by Friday rather than Sunday. So that last week, you don't get the weekend. I'll open up the exam on Tuesday, and you'll have from Tuesday until Friday to complete it. Okay, and it will be all inclusive. So um, it'll be chapters 1 through 15, not just where the quizzes were on. The questions will probably not be the same questions that were on the quizzes. It'll probably be a separate exam. Some of the questions might be on there, but it's going to be new questions for the material. It's not going to be tricky. I pretty much write my exams from chapter 1 through 15. So it's open book. You'll be able to use your books. So as you go through your exam, it's just probably going to be chapter order. Yeah, there'll be 2 attempts. Only 1 attempt on the final. Okay. Any other questions? Okay. The grading scale is very simple, just by percentages. So whatever percentage you get, 94 to 100 is an A minus 90 to 93. And yes, if you have an 89.5, I will bump it up to a 90. So whenever I can do that, I always bump it up if possible. But I do use the regular laws of rounding. Okay, and so 90 to 93 is an A minus. B plus is 87 to 89. B is 84 to 86. B minus 80 to 83. C plus 77 to 79. C is 70 to 76. And then D is 60 to 69. And below a 60 is an F. Okay. If you do have a question about your grade, sometimes when you all submit things, I just don't see it, especially if it's late. If it's late, email me that you submitted something late. I don't usually take points off for it being late, but I just need to know that it's late because sometimes if you don't tell me, then I won't look after it's already time to be turned in. So be responsible and just let me know if you've turned in something late. In general, I don't usually care too much if it's uh, late a couple of days, um, but obviously you can't turn your final in late because there's no more time left. And your APA paper is due 2 weeks before the end of the semester, and you can't really turn it in on Friday of the last day of the semester hoping that I'm going to grade it, because it's not fair to me, and it's not fair to the other students who submitted their paperwork and stuff on time. I'm pretty easygoing though when it does come to late. And just if you're running late for some reason, tell me before it's due. That way I can make sure that um, I know that it's coming. Okay. I was a student, obviously, at many points in my life. Still am actually, and so I understand things get late. You know, you don't hear them but right now, but I got a 15-year-old dog that I got to put down this weekend, and stuff comes up like that, and I understand that that's just life. And with COVID-19, I know lots of students have lost family members and loved ones. Those things, that's part of life, and with job situations, just let me know if something's going on. Don't be afraid to reach out. I am also a therapist, so I have compassion for my students. And I say all this because if we can get things worked out, then there's not an issue about questioning a grade because we're up to speed and you'll know. Okay. And if you need any extra time or anything, make sure that you go through Mr. Ben Martin here. He is the gentleman who is your contact. Here's his contact information. If you do have a disability and need some help, either with some um, extra time for a test or whatever. Now, to be honest, I give plenty of time for all my tests and quizzes. I mean, like so much time uh, that really it shouldn't matter. I pretty much give everybody an extra amount of time. Um, you'll get 2 hours for your quizzes, for instance, and most of the quizzes are done in 15 minutes, so you'll have plenty of time. Uh, please use your academic success center. Um, that's what they're there for. They're there to help you with study strategies, reading techniques, the writing center for your APA paper. If you send it to them, they will help correct things for you. They're not going to change the content, but they'll help you with, you know, writing and style and making sure that it's APA formatted. Um, use them. It doesn't cost anything. You email them your paper, they email it back with all the corrections, and so it's a good thing to use. Again, the final exams, it is preferred that you use the email for communication with me, but like I said, my phone number, if you need to text me, if it's something that I can't just answer you, I'll email you the answer. Um, please, if you're here, you've already logged in, obviously, and have seen your coursework stuff. But if you have any friends that are in the course with you, if you know that they haven't logged in, make sure that they log in by this weekend. Otherwise, they may be dropped from the class. There's grievance procedures, etc. We do use technology. We don't use live text here. Safe assign, or there's not really going to be any reason to use TechSmith Relay. Um, here is the breakdown of the coursework. And so this is the first week here. Read chapters 1 and 15, introductions, discussion board due. There's also, wherever it says read chapters, there's also the PowerPoints that are available too. Week 2 is reading chapters 2 and 3. You're going to do your DSM-5 activity, which is due January 31st at 11:59, and quiz over chapters 2 and 3 will be due at 11:59 on the 31st as well. My quizzes are going to be 20 questions. I might give a 21st question as an extra credit. Um, I'll see how classes go, how the class is doing overall, whether or not I include extra credit. If everybody's doing well on the quizzes, then there'll be no need for extra credit. But if some people are doing not so well on the quizzes, then I'll help everybody out by giving some extra credit on the quizzes as we go along. Probably not the first or the second or the third week quizzes, but after that there may be. So you will have two chances, so make sure that you use both chances. Now the quizzes themselves will be randomized, unlike the final exam, which will be pretty much in chapter order. So February 1st through the 7th, we have chapters 4 and 5, quizzes over chapter 4 and 5, and by that time, I'll have a discussion board up by that time, and you'll just submit your topic that you want to do your research paper on for your APA paper. And those are due to me February 7th. 11:59. Week 4, February 8th through the 14th. It'll be Valentine's Day. Chapter 7 or 6 and 7, and quizzes over chapter 6 and 7. Week 5, chapters 8 and 9, quizzes over chapter 8 and 9. Again, due Sunday by 11:59. Week 6, chapters 10 and 11, and quizzes due over 10 and 11. Your APA paper will be due in week 6 on February 28th at 11:59 as well. If you want to submit it to me the week before, if you get it done early enough and you want to submit it and have me go through it, I'm more than happy to do that for you. So keep that in mind. Don't give it to me the day before and want me to go through it for you the day before, because that's probably not going to happen. But if you work hard and you get it done the week before, or even the Monday or Tuesday that it's due before, then I'm more than happy to look through it and basically grade it for you, give it back to you so you can fix whatever I put down there. I want you all to be successful, and so, but it also depends on you and your diligence in getting things done early enough for me to help you be successful. Okay. Week 7 is chapters 12 and 13 with a quiz over chapter 12 and 13. And then week 8 is reading chapter 4, and the final exam, which will be all 15 chapters, will be available after March 10th and will be due March 12th, which is a Friday, I believe. And that's the course. It'll be going by faster than you know it. And just stay on top of the stuff that is due. Again, there's not really any surprises here, just the paper, the topic, the paper, and the little things like the quizzes and the discussion board. So, any questions on the syllabus? Okay. Let me see. So then we can go down to chapter 1 PowerPoint, and these are all available to you as well. So just an introduction to abnormal psych, and that's what this whole course is. It's just a survey of it. You're just going to go over. Most of the individual chapters could be classes in and of themselves. So especially if you want to specialize with a certain population or anything. All right. So a mental disorder. What's the history of abnormal psychology and abnormal psychology in life? Different themes. 3 criteria determine abnormal behavior: deviance from the norm, so whatever socially is acceptable, adapting to one's life's demands, and the experience of personal distress. The 4 of us could watch the same car accident, and 3 of us might be fine, and the other person develops PTSD from watching the car accident. Each one of us reacts to life and stress differently. And so that is something that really plays out in mental disorders. So first thing is deviance from the norm. We've got this chart, and so on the outskirts of it, which is basically 2 standard deviations from the norm, is what we have as far as abnormal. And so either too high or too low. And most of us live in this area. That would be the deviance from the norm. A lot of times we use our own gut judgment or gut feeling. Different cultures have different norms. What might be considered normal here in the United States could be considered abnormal in Saudi Arabia or in Japan, even closely related to Western cultures. What we do normally here might be considered abnormal in Europe, which is relatively a similar culture, but still there are some differences in what's what the norm is. For instance, one obvious norm difference is uh, a lot of families go to the pub over the weekends and they participate in um, not just the family, but it might be the family, the grandparents, it might be aunts and uncles and their families. They might all go there to experience, a social gathering at a pub. And the a difference in norms is that at 16 you can drink in a pub in England, and so we don't really see that here in the United States where everybody goes to the bar. I mean, especially down here where there's still a lot of dry counties, right? So it's a little bit different, the norms here than what's in Europe. Difficulties adapting to life's demands. So when people get into a position um, such as going to school, right? Sometimes you did really well in high school, but now you get to college and you're working a job, maybe you have children. There's a lot of stuff going on in your life, and uh, what used to be simple is a lot more difficult. And so, going to school now as uh, a young adult or even a non-traditional student becomes a little bit different. And so, if we don't adapt to that, then that could lead to um, being abnormal or having an abnormal experience. And then finally, experience of personal distress. So I don't want to just read right off of these things, but these are all things that are really um, important as far as considering mental health issues. Emotions, good alertness, positive, and then we get to the continuum. It's mild, feeling sad or down, but not for long. So a lot of the things that determine whether or not somebody has a mental health issue is the length of time somebody experiences distress, or the length of time that somebody experiences sadness or anxiety, etc. And as we continue down the continuum, it gets from moderate to mental disorder, less severe, mental disorder, more severe. Some things that they used to do, I mean, 460 BC, exorcisms, trephination. Anybody know what trephination is? Putting holes in the head to let the spirits out. Yeah, seriously, they used to carve a little hole, and for some people, they actually got better when they did that. Maybe they were suffering from encephalitis or some other brain pressure, but sometimes trephination actually did work. We know that it worked because we have skulls that the holes that they put in them healed from. At least they survived the surgery. So, I'm not sure how much it actually worked as far as behavior. For the next almost 1,000 years, therapeutic environments, healthy diets, exercise, massage, education. You know, they used to put people in sanatoriums or sanitariums, right? Uh, Places where they thought they might send them to a hot spring because of the healing properties of a hot spring. And so, if there was like a hot spring, a whole, I really wouldn't call it mental health, but there would be a whole um, like a doctor symposium that would spring up around it, and they would try healing people from that. And then, of course, as we continue on with um, religions and things like that, prayer, holy objects, relics, pilgrimages, confinement, exorcisms continued. Hippocrates believed that abnormal behavior resulted from brain disorders or dysfunctions, and that led to a scientific approach to learn about what are the causes. We have the Middle Ages. A lot of times they would try to exorcise demons. If somebody was mentally ill, they thought they had a demon or that they were cursed, and they would perform exorcisms or pray over the person. During the Renaissance, they would start obviously with this is really where sanitariums and putting people in a specific place for healing or to be kept if they were dangerous to themselves or to society. And so here we have a picture of that going on. With the reform movement, they saw that the places that they were putting people were not very healthy. The people weren't being taken care of. They weren't being treated as human beings. And so with the reform movement came better treatment, really helping people try to get back into society, try to figure out what the root of the problem is and moving them forward and trying to reintegrate those people who are capable back into society rather than keeping them isolated. And this gentleman actually, I'm horrible with names, so I apologize, but this gentleman entered into an asylum and wrote a book about his treatment. And then when he came out, contributed to the reform movement because people just found it unbelievable, his experience, that people would be treating the sick people the way that he was treated. So looking at it from a dimensional perspective, again, we have the continuum. And the best, obviously, is to live in this area here. As we continue to get more severe, there has to be more, I don't want to say invasive, but stronger measures taken to help the individual. At mild, there may or may not be a need for medication. In moderate, there may or may not be a need for medication. Usually by the time we get to mental disorder, though, that's where medications start to come in. And if it's severe enough, whether it's emotional, cognitive, or behavioral, then being restrained, going to a place for help and specialized help, living in a home, things like that may be necessary. The concept of mental hygiene, types of prevention, primary, secondary, and tertiary. And looking at it from the consumer perspective, helping people understand mental health. You know, most places, and this is going to be in your discussion board if you've already done it, there's stigmatism of mental health. You know, we're either going for services or not going for services. And, you know, me personally, I've been in recovery for 26 years, which is a mental health substance use disorder. Uh, I had a pretty horrific childhood. If you do any research and you know anything about ACEs, I am a 10 on 10, 10 out of 10 on the scale of the ACE scale. You know, and if it wasn't for people who were counselors and willing to help me with substance use, I wouldn't be here. You know, and so I am an advocate for not being shy about getting better for mental health. You know, I've suffered from PTSD. I was a Marine, all kinds of things. And today I would definitely fall in the normal spectrum, but it doesn't come without effort and acknowledgement and the willingness to do something different. And, you know, and so I am definitely an advocate for being okay to share, you know, my past experiences. So, learning about diversity, you know, one of my favorite populations to work with is the Native American culture. And I've had the opportunity to work with children and with adults and in all different parts of the country, and with the LGBTQ community. Diversity is just an amazing thing as far as working with treatment. You know, the first DSM, Diagnostic Service Manual and Statistics Manual, believe it or not, being gay was a mental health disorder. And, you know, it was right there in the DSM. And it would be, I think it wasn't until the DSM-3 that it was removed as a mental health disorder. And so other things come and go off the DSM-4 or the DSM as it gets older and as it meets the needs of the culture that we're in. And so it's pretty interesting just the history of the DSM development and with respect to diversity. So, like I was talking about stigma, a lot of times if a person has mental health issues and they know that they're separate, they're different than other people, they put the self stigma on them. They believe that they're incompetent or um, that they're not going to be successful in the treatment of it. And so, why go get help if it's not going to be good? Some of the stereotypes of stigma from the public: people with mental health or mental illness are dangerous, and so they discriminate. They don't want to hire people with mental health. Again, stigma can be addressed by providing factual information about mental disorders. Um, people with schizophrenia, believe it or not, have a 71% chance of recovery. And it doesn't have to be active in their life all of their life. It's pretty amazing. Um, Depression, anxiety, these things do not have to be lifelong, and people do not have to maintain medications lifelong. They have the ability to get better from it. Uh, we do this by the facts, noting the symptoms of mental disorders are present to some degree in all of us. As you go through and you read the DSM-5 stuff, you're going to be like, oh man, I got this, I got this, I got this. But the thing is, you got to remember that you might have that symptom, but you haven't had it long enough or severe enough to actually meet all the criteria for the actual disorder. All of us get anxious. All of us get sad. You know, if we see something that's traumatic, we're going to have acute trauma. You know, now whether or not that trauma becomes post-acute, right? Whether it becomes PTSD versus acute trauma depends on the individual. And even if it becomes PTSD, it doesn't mean that it can't get resolved. So, learning how to do that, emphasizing people first and mental disorders later. What they mean by that is, we say that so and so is a person with schizophrenia rather than calling them a schizophrenic. We say that people are people who have alcoholism versus alcoholics, and people who have bipolar disorder are people who have bipolar disorder rather than uh, you know what manic depressive is the old term that we used for bipolar disorder. So um, we don't label people. They're people first, and then they have mental health issues later. Reading firsthand accounts of individuals with mental disorders helps become a human. And so, as you look back on chapter 1, what are the implications of a dimensional viewpoint? How is abnormal psychology relevant to your life? And what have you seen as far as stigma goes? And that last question is actually basically your introduction question. So, uh, be considering that. Any questions regarding chapter 1? Okay. And then we'll jump to chapter 15 and we'll wrap it up. Did you guys see that, by the way? I don't even know what you all see. Did you guys see the PowerPoint? Oh, okay. So here we go. Sorry about that. You guys could have stopped me at any point instead of me just rambling on. Now you see it? Okay. Okay. So now we're all on the same page. Sorry, speak up. Don't be afraid to speak up. I'm a human being. I make mistakes, and especially with technology, it's not my forte. So, with okay. Um, Chapter 15, the Consumer Guide to Abnormal Psychology, and my personal belief is that when you go on to your master's level, my program had me actually. I mean, I'd already been a client anyways because you heard a little bit about my past, but um, I believe that it should be mandatory that we all go see a clinician for at least five weeks or five individual sessions, just to get the experience of what it's like to be on the other side of the seat, as you go forward in your career. I think it helps us remember that there's a person on the other side, and and so becoming a consumer, to the abnormal psychology is important. And as we go through here, there's different types of therapists and qualifications. Clinical and counseling psychologists often work in private practice settings. Um, if you're interested in a career in psychology, I actually started off in psychology and I ended up in counseling. And you're like, well, what's the difference? This explains a little bit of the difference, and I'm going to add on to that difference as we go forward here too. So, as a person with a mental health issue or a cognitive issue or a behavioral issue, um, it's nice to have a counselor or a therapist who is warm, supportive. Um, that's the relationship. No matter what type of counselor you are, no matter what kind of philosophy you come from, almost the entire outcomes, all the positive outcomes are based off of a good relationship with your therapist. You know, they found like I think it's like 85% of the relationship they have with their therapist indicates the outcomes rather than the 10% of the philosophy or the type of therapy used and other factors. So relationship is one of the biggest things. You're as a client, your ability to understand and self-examine thoughts, behaviors is a key aspect of therapy. Um, the therapist is often a facilitator of the individual's mental health. And if the individual isn't capable of self examination of thoughts and behaviors, then it makes therapy a lot harder. Um, it restricts, like, for instance, cognitive behavioral therapy. If you can't look at your own cognitions and your own behaviors, then CBT won't be very effective for you. Behavioral therapy by itself might be something that's effective, and that's why behavioral therapy is often used in children because they don't have the ability to cognate, look at their own stuff, look at their own thoughts, look at their own behaviors, which is why behavioral, the STAR system, and things like that work well with children when we look at just behavior. So that's an important aspect. Appropriate expression of strong emotions uh, is sometimes a part of successful treatment. Uh, there's lots of different perspectives, especially like dealing with trauma. Some people are able to talk through their trauma and get better from it, even though the trauma was very grievous. Other people, when they talk about their trauma, all that happens is they get re traumatized and there's no healing. And so there are a variety of ways to treat trauma. And for instance, there's EMDR, which is using a little machine, and it's a way of doing biofeedback that's non invasive when it comes to trauma treatment. Does it work for everybody? No. It works for a lot of people, but not for everybody. Some people, like me, I went to and just did talk therapy for my trauma, and it was successful. So it really depends on the individual and learning how to deal and sit with strong emotions it can be very difficult. Do any of you have current experience working in mental health or with people with mental health issues? No. Okay. So, prescriptive treatment examples, these are things that tend to work best with different things. So, CBT, cognitive behavioral therapy, works good with anxiety, depression, eating disturbances, sexual dysfunction, schizophrenia. Dialectical behavioral therapy works best with borderline personality disorder, um, behavior modification for autism, and medication for bipolar disorder. Self-help groups offer support and guidance for people with similar problems. You know, recovery, but NA, but also depression. There's groups out there, self-help groups for depression. There's self-help groups for divorce. There's self-help groups for a variety of issues that we experience as human beings. And so it's important to differentiate, though, that self-help groups are not usually led by a professional. They're usually led by laymen who are helping each other out through this issue. And so there may or may not be a therapist available in a self-help group. When things are more severe, there may be a need for aftercare or residential facilities. Some kids and individuals or adults um, may have difficulty living on their own. Uh, Down syndrome is a case. There are high functioning Down syndrome individuals that are capable of getting a job, paying rent, having their own apartment. And then there are a lot of them who aren't functioning well enough to, they have some independence. They can go do work, but they can't live on their own. They can't go back and forth to work without somebody bringing them back and forth to work. So they might have to live in a residential program. The criminal justice system, more and more, it's always in the news, the decriminalization of marijuana. And, some states like Washington State have decriminalized cocaine and other drugs too, amphetamines. Um, they don't want people to go to prison for that stuff. They want them to go to treatment for it. And so, as it should be, because addiction is not a criminal issue, it's a societal issue. It's a substance use disorder. And yes, the behavior from these individuals who have addiction often cross the line into criminal, but their issue isn't criminal, it's the substance use. And so it's really important to understand that difference. So there's always limitations. A poor therapist client relationship. And it doesn't mean that the therapist isn't any good. It just means that the relationship between the client and the therapist isn't working out. As a clinician, if I feel like it's not working out for whatever reason, I want to have a conversation with my client about that. I want to say, hey, you know, we've met for 4 or 5 weeks, and it doesn't really seem like we're building a relationship here. What's your experience? And when they say, yeah, it doesn't really feel that way, and we talk about it and we try to correct it, but sometimes it can't be corrected. So you have to refer that person out to somebody else who might be a better um, fit. And it also goes the other way. The client might say, hey, this doesn't really seem to fit. Can I have a referral? And so we really want to make sure that we're following the ACA code of ethics, first of all. And the basis for that code of ethics is often, is there a benefit? Is there beneficence? Is it actually doing harm? Is there malfeasance? Is there autonomy? Are we encouraging them to make decisions and support themselves? Things like that. It might be a poor choice of treatment. I might be working existentially with somebody and they really need CBT. So working and making sure that person gets to the right program. Treatment noncompliance. I've worked in addiction for 20 years now, and it's really hard to work with somebody who's always getting loaded. At some point they have to stop using in order to be treated, and so that can be an issue. And just personal therapist client differences. We're all human beings, and not every human being is going to get along. And so making sure that the client therapist relationship, the differences aren't so great that they can't do work. With managed care, it's usually the only benefit is lower cost. They're not able to choose a provider, and it's a lot harder to say, I'm not really working well with my client, my therapist. Can I have somebody else? Especially in a rural community where there may only be one therapist, right? Unable to choose the treatment, you might be stuck with somebody who only does behavioral therapy. Maybe they're not very well versed or trained in other types of therapy, and so behavioral therapy is what you get, even if it's not what's usually called for as far as the disorder or what's being treated. And another thing with managed care is that it's usually time limited, often, maybe 6 to 8 sessions, sometimes longer, but it's really hard. And so they tend to pick therapies that work briefly. Me personally, I'm more of a psychodynamic therapist. I believe that the events in early life really impact how we behave and act and think and emote later on in life, and that unless those things get resolved, that the problem will persist. And so usually you have to take a lot more time in psychodynamic type theories than you do in brief therapy, right? So it's just how it goes. So I might have a difficult time getting clients and keeping them in treatment if they have insurance that only wants to pay for 10 sessions. Everyday practice can differ from everyday situations. Um, Research is really good at setting up and looking at the way things are set, but research doesn't always translate to good treatment. And so, really being able to take in the research as well as apply it to who your clients are and what the situation is a very important aspect of um, treatment. The misuse of research and weak research. So is the sample in the study diverse and representative of the general population, or is it all Caucasian kids who were 12 and 13 years old? How am I going to apply that to an African American adult? Is it going to? So it's really important to really look at the research and who is being studied as to how well it's going to actually apply to maybe your circumstances. Were there enough participants in the study to obtain a meaningful effect? If there was a case study and there were only four clients that you did this new thing on, how well is that going to translate? How powerful is that going to be to try to practice on 100 people? So you may need to have more research done on something that was a case study, for instance. Are the dependent measures in the study varied and of good reliability and validity? And that's more research jargon that if you haven't taken your research course yet. Reliability is how consistent something is, and validity is how meaningful it is. And so I could set up an experiment in my laboratory and get really great results because everything is structured and this happens when this and this and this happens. However, take that same idea and put it out in the real world where there's chaos and it may not work out. So did the researchers rely on information gained from different sources such as clients, parents, teachers, spouses, children, and peers? Especially when we're talking about mental health of somebody. Some kids might do really well at school, but then do act out a lot at home, or vice versa. They do really well at home, but then they act out at school. And so it's important, especially when we're talking about mental health of children, to get as many people involved as possible in the evaluation process. And one of the biggest things that happens, and especially down here in the Appalachia region, is access to treatment. Some of the rural communities don't even have a therapist. They have to travel 30, 40 miles to get to a therapist, and that's really hard because they don't have a vehicle. So, how do we provide services, psychological therapeutic services to everybody? How do we do that? Medical services, things like that. And here are some words that you already hear me say: beneficence and non-malfeasance, protecting the welfare of others; fidelity and responsibility, acting professionally towards others, no matter what their beliefs are or your beliefs are. We want to provide consistent care to everybody that comes across us, sits across us from one chair to another. Having integrity, employing high moral standards in one's work; justice, or exercising fairness and reasonable judgment. If I'm working with a whole population of individuals and they all come to me from the same with the same issue, uh, maybe they all come from school and there's uh, prejudiced teaching going on there. I don't know. I want to make sure that I become an advocate for them when I see this pattern of things coming up. And of course, respect for people's rights and dignity, valuing others and minimizing conflicts. If you're working with somebody from a different culture, then it's your responsibility to do as much research into their culture as possible. It's not their responsibility to teach you their culture. And you don't want them explaining their culture to you, because that's a lot of time that's kind of being wasted. You have to do some research on your own in order to help meet those people where they're at. With assessments, we want to make sure that you keep tests secure. You want to make sure that the test is something that's going to be viable for the population that you're working with. And understand, you can't give somebody a test. Usually there's several tests that you have to give in order to come up with a reasonable diagnosis or conclusion. And so we don't want to base everything off of one test, because that test might not be what that person really works well with. Husband and wife communications are considered privileged in our society, as are communications between a therapist and a client. So once we start that relationship, this is all part of your informed consent as well, but you're going to set the standard as far as what data, what information you're allowed to talk with outside of that relationship that you have without their written consent. Dr. Phil is a popular media psychologist. Psychologists who speak via the media are still expected to comply with ethical guidelines. And so, just at the end of the chapter, the advantages, disadvantages of self-help groups, especially in contrast to seeing a mental health professional. We can talk about these if you'd like, or just keep them as something to ponder. It's up to you guys. I don't want to keep you any longer than I have to. I appreciate you all coming out, by the way. I'd be doing this for an hour and 5 minutes all by myself if you weren't here. So I appreciate it. Any thoughts on wanting to actually discuss them, or you're good? I'm taking it we're good. Okay. So, um, any questions on chapter 1 or chapter 15? Okay. Uh, if there's no other questions, anybody questions about any of the assignments or anything that's due, anything coming up? All right. Well, thank you for coming. And for those of you who signed in, Um, would you want to do this again? I plan on doing it for every week for the 2 chapters that are due. Um, okay, okay. Um, does 5 o'clock usually work for most nights? Do you like Thursday night? Is there a better night? So Casey's okay, and everything I send out for meeting, etc., is always East Coast time. So uh, I just want to make sure that because sometimes the email that comes out, always pay attention to what I write, not necessarily what the email says, because our email comes from Central Time. Uh, just so that you're aware of that. Sometimes when they do my calendar stuff, it'll say uh, Central Time instead of Eastern Time. But yeah, so if Thursday nights at 5 works, then that's what I will do. And I'll do it for the rest of the semester. Always feel free to email me or if you have a question or anything. But I'll go over the assignments due that week, and we'll go over the PowerPoints. And I'll give you any insight that I have from my own personal experience as a clinician, or and feel free to ask questions, especially when we get into diagnoses and things like that. So, anybody have any questions before we wrap up? All right. Well, awesome. Thank you for participating. Yep. And always remember, it's not mandatory. So, if something else pops up, I really got to stress that because we'll get in trouble if we say that it's mandatory. Um, so, it's definitely not mandatory, but I appreciate you all giving up your time. All right. Have a good night. Bye.